Good morning, and thanks, Bruce, and thank you for the association for the invitation. The purpose of the talk in the next few minutes is just to give you the clinical outcomes of our robotic single-site cholecystectomy multi-center trial and give you the complete outcomes and the analysis of it. These are my disclosures. So the overview, I'm going to talk about this Rossic study. We're going to talk about the outcomes, and then we're going to give you the conclusions of what we learned from these cases. A bit of overview about this study is that it's a retrospective review of outcomes of single-site cholecystectomy in a cohort of 500 patients and from 5 different sites. And our purpose was to collect and analyze the 30-day perioperative outcomes. 5 sites, 6 surgeons. We had 2 surgeons down at Baptist Health, South Florida. The cases were performed from January 2012 through September 2013. We were going to review a maximum of 500 cases. Inclusion is really all patients, 18 to 89, who underwent a robotic single-site cholecystectomy with one of the study surgeons and up to their allocation, because every site had a maximum allocation. There were no exclusions criteria outside of basic age exclusion. So the 5 sites are as follows and distributed as you can see here, and the numbers on the right are the maximum allocation that each site would have. The second site, Florida Hospital, Orlando Florida Hospital, had a maximum allocation of 50, but they completed 23 cases. And that gave us a 473, and really the number of cases that were analyzed were 465 due to a miscalculation at our site, where we were 8 cases short on analyzing. When we went back and looked at it, we thought we had collected 200, and we had collected 8 short of that. These are the sites. Some of the demographic outcomes, age well distributed among all ages, from the young to the elderly. Mean age is 48, the majority women, of course, because gallbladder disease is mainly in women. Ethnicity, mainly white, non-Hispanic. And then BMI, mean BMI of 27 among all 465 patients, and well distributed as well. ASA class was mainly ASA 2, and the primary indication in most patients was symptomatic cholelithiasis or biliary colic, though we did have some cholecystitis, biliary dyskinesia, as well as even pancreatitis. And then you can just see the distribution on the right per site. So some of our outcomes, operative time, median operative time of 52 minutes among all sites. Console time in those that collected console time was 21 minutes median. And length of stay for 432 cases where we were able to extract, the length of stay was a median of 16 hours. You can see by site that there is a great variety in operative times among different sites, and so some sites had operative times of medians of 40 minutes and some as high as 80 minutes. Big variety, but the median operative time among all sites was 52 minutes. Operative approach, 97–98% were able to be completed via single incision. Intraoperative cholangiogram was performed in 2% of cases. And there were concomitant procedures, and I bring your attention to there were 3% of cases that had a concomitant robotic procedure, and this is going to be a little more important later in the discussion. Some of the other postoperative outcomes that are maybe interesting to us as surgeons: bile leak 2 to 0.4%, and there were no reports of any of these other types of complications below, especially no reports of bile duct injury, which is important for cholecystectomy. Other postoperative outcomes that were reported, things like skin infections and even diabetes out of control and so forth, even episodes of diverticulitis unrelated, but obviously we were very thorough in the collection of all 30-day postoperative outcomes. So what are the risk factors that increase operative complications? And we saw that if if additional ports were placed or there was a conversion, then the complications were increased. And obviously they go hand in hand, and a 10-fold odds ratio, the addition of ports or conversion to another manner besides single site obviously led to increased complications. Other factors we learned and other predictors of extended surgical time were male versus female, obese, BMI of greater than 30, 2 times more likely to extend your surgical time. Diagnosis other than biliary dyskinesia, so cholecystitis, cholelithiasis, biliary pancreatitis. A concomitant robotic procedure as well, and that's what we talked about. Obviously doing other procedures that are not on label for the robotic single site, performing those during the robotic single site cholecystectomy obviously would increase your operative time. So what about learning curves? And we broke up learning curves among surgeons that had different volume of cases. And the first learning curve is for one surgeon, the first surgeon that had over 100 cases. And what we learned was that after the initial 50 cases, there was a leveling off of times. I can tell you in this surgeon did complex cases early in the experience, and so there was not a beginning phase of simple cases and moving on. All types of patients were included in his experience. And then there was a decreasing in time after 85 cases. The second surgeon that had over 100 cases was less variable than the first, probably because of the demographics and the diagnosis of the actual patient. But after about 30 cases, there was a leveling off of times and decreasing steadily after 70 cases. The two surgeons that performed at least 75 cases, we noticed that there were stable initially and then decreasing around 50 to 60 cases. So our conclusions of this study is demonstrated that the robotic single-site cholecystectomy is feasible across all groups of patients, no matter the age or the BMI. Complications were a rarity, and more important than that, there were no bile duct injuries. Surgical time was reasonable, but there was a variety among different surgeons in different centers. 98% of the cases were able to be completed via single site approach. The predictors of a difficult case, prolonged surgical case, would be male, obese, diagnosis other than biliary dyskinesia, and a concomitant robotic procedure. And then the learning curve was that we learned that it leveled off at around 50 cases and decreases at around approximately 70 cases. Thank you for your attention.